at Vibrant Emotional Health, home of the National Suicide Prevention Lifeline. Prior to joining Vibrant, she was the operations manager for the National Action Alliance for Suicide Prevention. And in this role, she was responsible for organizational strategies, protocols, and policies that support and advance the Action Alliance's infrastructure. She also provided technical assistance to Action Alliance partners and facilitated the work of multiple Action Alliance task forces that address health systems transformation, suicide-related data and surveillance, and military and veteran populations. She has over 10 years of experience in public health. Across her career, she has led and facilitated public health programs in mental health, suicide prevention, substance misuse prevention, and obesity prevention. She received her undergraduate degree in history from Penn State, her master's degree in public health from Boston University, and is currently enrolled in a Doctor of Public Health degree program with a focus on social marketing through the University of South Florida College of Public Health. I got to meet her when she worked at Penn State, and I'm really excited to be able to have her back and to hear her presentation tonight. So Farah, thanks so much for coming, and we look forward to hearing from you.
Thank you so much for that really warm introduction, and it's so nice to see everyone and meet everyone here. I don't often get to present or interact with public health preparedness students. So having worked with the Master of Public Health program back in the day at Penn State, I really enjoyed working with students. And so I'm so excited to be presenting today. I am going to go ahead and share my PowerPoint. I'm going to keep it in this mode because I have some talking points I have on the side here that I want to make sure I touch on. So I'm not going to put it in the large PowerPoint mode. Can everyone see this okay?
Yes.
Yep, it looks good.
Yep.
Perfect.
Good.
Okay. And if you have any questions that we don't get to in the discussion today, feel free to email me. I put my personal email address here. You're welcome to contact me at any time. I did want to give a disclaimer before I start that I'm not representing Vibrant here. I'm just representing myself, my experience, my perspectives, what I've seen and heard over the past, 3.5 years or so. And I just started my new position on Monday of this week. So while I've already learned and seen a lot at Vibrant, and I will touch on some of what I've seen and heard. I'm certainly not representing them yet at this time. So today I'm going to talk about suicide prevention before, during, and in the aftermath of the pandemic. And this, another disclaimer is this is really just a broad overview. I'm just going to skim the surface here. We could go an hour or more in depth on any of the issues that I talk about today or questions that you might have. But I just wanted to provide this broad scope overview today. So before we start, I really want to know, I think this is a small enough group. I would love to know a little bit about you, who I'm talking with today. If you can either unmute yourself and say who you are, where you're from, what industry or sector you're working in right now, and what's not written down here, but if you can say kind of what interests you about this topic, I think that will be really insightful. So feel free to either put it in the chat or unmute yourself. Any volunteers?
Well, I'm JD Tooney. I'm currently in the web development realm, but I'm looking to transition into the emergency management area.
Okay.
So that's me.
Awesome. It's so nice to meet you. And where are you based geographically?
Jackson, Mississippi.
Okay.
I'm a Texan who's transplanted to Mississippi.
Okay.
Other people want to, we've got one in the chat. If anybody else wants to speak, if you want to just use the raise hand icon, and then we can go down the list and call on you.
Perfect. So hello, Ashley. Oh,
yeah,
go ahead.
No, I was just going to ask if you could see Ashley's in the chat. Okay.
Yes, Ashley, currently working for HUD as Community Planning and Development from Boston. And Ashley or JD, what interests you about this topic, or anybody else, if you want to go ahead and volunteer that.
Can you see the raised hands on the chat?
I can't, but you're welcome to, if you want to go ahead and call on people, if you can see that.
All right, let me. JD, Ashley, do either one of you wanna take that?
For me, I mean, it's just a matter of I got interested in community emergency response teams, and discovered that I really liked the feeling of service, giving back, and the whole topic was of interest too. You know, it was just a new calling, I should say.
That's fantastic. And very relevant to suicide prevention, especially some of the things I'm going to talk about. And hello to Cheyenne from Alaska. That's so cool. Okay. Jean, thank you. Well, why don't I go ahead, continue? Oh, go ahead.
We have one more person with their hand raised. So do you want to go ahead and introduce yourself? And we also have chat.
So I'm Aditya. I am currently studying international affairs as a master's, and PHP was something I was interested in. I'm trying to go into disaster risk reduction and mainly focusing on recovery. And so I was really interested in the public health aspect of that. And this particular webinar was more interesting because of my experience with volunteering with kids.
Okay, wonderful. Thank you. So why don't I go ahead and just to make this even, I'll tell you what brought me into this work. You know, a lot of people who work in suicide prevention have personal experience, and that's what brought me into this work originally years ago. And I found that, you know, maybe perhaps working in any field that is mission driven, you know, it's a group of very passionate, dedicated, committed people. And I imagine it's the same for emergency services and public health preparedness and, you know, any of the various industries that you might represent either now or down the road. And even though suicide itself is a really hard topic, it can be a really hard topic to talk about and investigate. Working in this field has been one of the most inspiring, rewarding experiences of my professional career, hands down. And it's just, you know, getting to wake up every day and do this work is something that, you know, it has been such a rewarding experience. And one of the things that I think I found most rewarding is the connections with people from all different sectors. So I'll touch on this in a moment, but I think with any really complex public health issue, it takes a village. It requires involvement and investments from so many different sectors and industries, from community-based settings to the federal government on the public sector side to private sector as well. You need Veterans Affairs, you need defense, you need you know, corporate leadership and industry-specific leadership and people with lived experience all to come together. And I've met people from all over the country. My team has been from all over the country, and it's just been really rewarding and fascinating and powerful to be able to work with people across different sectors. And I hope you all have that same experience going into public health preparedness related employment, whether that's, you know, you're in that now or you're seeking that in the future. It's just incredibly rewarding. So some of the goals for today, again, this is really a broad overview. I'm going to provide a very brief overview of some of the data just to give you a snapshot of suicide as a public health issue in this country. I want to briefly discuss some of the key challenges and opportunities in suicide prevention today and touch on the impact of the COVID-19 pandemic. I'm going to talk about that as a challenge, but also as an opportunity. And I also want to briefly touch on priorities for the future. I'd love to hear from you throughout the presentation. If you have questions, feel free to raise your hand. And Jen, feel free to call on them and interrupt the presentation as we go. You can put them in the chat as well. And then again, if you have questions kind of outstanding after this, feel free to email me and I'm happy to connect with you. Ultimately, I want you to walk away with some hope. Again, suicide can be a really hard topic to talk about. It can feel at times hopeless, especially if you're reading the news all day. But I want to paint a different picture for you. And like I mentioned, this can be a hard topic and it can touch everybody's lives in some way, shape, or form. So I always want to put this on the screen at some point when I'm talking about suicide, that if you or someone you know is struggling or in crisis, having a hard time, you can call the National Suicide Prevention Lifeline. These are all 24/7 resources. If you don't want to talk to somebody in person, you can send a text. These resources are for people seeking help for themselves and for others. So consider these resources. I want to make sure that you have them. I've actually contacted these resources before, at least one of these resources for help for myself, and found it incredibly helpful. So people are there, they're ready to answer the call or text or chat. Just want to make sure you have this.
We're gonna post a recording of this on,
Okay.
we'll post it in the classes, and I will also post it in our LinkedIn group, but I will also take the information on this slide out and put it in those places as a standalone post. So that way
Awesome.
It's easily accessible if anybody needs it.
That's fantastic. Thanks for doing that.
Oh, you're welcome.
So just as a brief overview. So one caveat here is that the most recent data we have on suicide is already 2 years old. And I'm going to talk about that as a challenge in a little bit, but I think it's important to note up here that right now the data we have are old and outdated, and it's the best available data that we have, unfortunately. So reported suicides from 2018 are just the tip of the iceberg. So we know that at least 48,000 people died by suicide. This includes young people and adults. Again, it's just the tip of the iceberg. When you look below the surface, there's a larger issue that we're seeing. From federal data, we see that 12 million adults, let me clarify that, had serious thoughts of suicide in 2019. 3.5 million adults actually made a plan to die by suicide, and 1.4 million adults actually attempted suicide. I think it's important to note these are self-reports, so they're not always the most reliable data, but again, it's the best available data that we have at this time. And another thing I think this slide tells me is that not everybody who thinks about suicide actually dies by suicide. Not everyone who thinks about suicide goes on to make a plan or actually makes an attempt. And that tells me that suicide is preventable. There are things that we can do to keep people from getting from that state of being in a crisis, having a serious thought about suicide, and actually attempting suicide and dying by suicide. So I think even though, the slide can tell you a couple of different things, it can tell you this is a really huge, significant public health issue for the United States. And it also hopefully will tell you that suicide in itself is not inevitable. Here is, another way to look at the data. We often, in the field of suicide prevention, we often say, I think to try to tell the story that suicide is a major, issue in the United States, we say it's a leading cause of death, and it is a leading cause of death. But at the same time, I think it's important to see the data on the page here. Young people, while suicide rates are rising among these populations, young people they don't typically die. If they are dying, it's from things like genetic diseases or cancers or unintentional injuries. Accidents are the leading cause of death for most people in this country across the board. Suicide is relatively rare compared to the other leading causes of death. And, as people age, while the numbers increase, people as they age get heart disease and kidney disease and cancers. And so those things displace suicide as a leading cause of death. So I think, this is important to see that, again, the suicide mortality is relatively rare. While it is a leading cause of death and it is a horrible, tragic health outcome, that it's not inevitable, it is preventable, and there are things that we can do. And again, also these data are 2 years old. So that's also, I want to point that out again. At the same time, over the past 20 years, suicide rates have increased. They've increased at a steady state for all populations, for all races and ethnicities. It has continued to go up, bit by bit over the last 20 years. We have right now preliminary data from 2019 showing that there was a very slight decrease in suicide rates. We don't yet know what 2020 will look like, though. We have no idea yet what impact, if any, the COVID-19 pandemic will have on suicide rates. We don't know what the kind of outlook will be, and we won't know for a couple of years, unfortunately. And I'll talk about that in a bit. Here's another way to look at the data. When you think about health outcomes in various locations, for suicide, rural frontier communities experience higher rates of suicide than urban and suburban locales. That could be for a number of different reasons. If you kind of dig deeper here, this is a very high level snapshot. If you look at the county level, you see there's a little bit more variation. This white area either is people don't live there, or there are too few people that you can't actually report on the data. But you can see there's some clusters here, in the rural areas. Not every county in say Nevada is experiencing super high rates, but there are some where rates are very high. And so this is, I think, it's important to see this level of detail here. Another way to look at this is by gender, but then also by race and ethnicity. There are certain populations in this country who are disproportionately affected by suicide, including American Indian and Alaska Native populations. We also see that men die by suicide more often than women. We also know that women attempt suicide more often than men, but men tend to use firearms more often, which are more lethal than the means that females use. So there are definitely some disparities here. And with the COVID-19 pandemic, on reservations, American Indian, Alaska Native populations, I think this year are getting hit extra hard. We don't know yet what the suicide rates will wind up being for those populations. We have no evidence yet that they're increasing, but mental distress and just overall distress among those populations are higher right now. Oh, backwards, forwards. This assessment came out a couple of years ago, again, based on 2018 data. The CDC took a look at suicide rates in different professions, and then they broke it out by female and male. And I think it's really interesting to see the differences here. That one, not surprising that males are experiencing higher rates than females in general, but how it breaks out by the different industries. So males in construction and extraction, arts, entertainment, sports, and media professions for males and females seem to have higher rates for suicide. Protective service, that could include law enforcement, it can include security positions, healthcare workers among females. I think this was really interesting to see the differences between professions. And, you can make some inferences based on the data what might be happening with these populations. Maybe for construction and extraction, it's more, there might be more job loss or job insecurity. or something else might be happening there, or more males, and so more males are dying by suicide using firearms, and so maybe that's what's happening. But I thought this was really interesting. So one thing that makes suicide a really complex public health issue is that, you know, it's not something you can send to the lab and have analyzed and reported. There's so many different risk and protective factors that may or may not result in a suicide death. There's no single cause for suicide. There's no single solution. It's, you know, could be the interplay of some or one or more of these that leads to a crisis. Someone has access to the wrong means, and that's what causes the suicide. But, you know, it's incredibly complex. You know, if you look at the individual level, you see mental illness, but not everybody who dies by suicide has a mental illness. And also, you know, I mentioned access to firearms. That, you know, is one risk factor, along with other means that people can use to die, you know, to kill themselves. But there are other things like unsafe media portrayals, which can be particularly harmful to young people. So if you know, after Robin Williams died by suicide, the news media descended on his house, and you know, there was very graphic reporting about his death in the news media across the country and outlets across the country, especially you know, pop culture mags and outlets online, especially those that young people might be prone to access. And there are do's and don'ts for reporting, which is what I'm studying, as I mentioned at the beginning of this call, what I'm studying in my doctoral program. But some of these can actually result in increases in suicide. And a study, at least one study was done that showed after Robin Williams' suicide, there was an increase in suicides when there shouldn't have been for that time of year. So, you know, there was somewhat of a cause and effect situation there with how the news media reported on that death. After Kate Spade died by suicide, there was an increase in calls to the National Suicide Prevention Lifeline. That doesn't necessarily mean that everybody who called actually attempted suicide. You know, you could see that as potentially a positive result, that people were aware of the lifeline and they were able to get access to crisis care when they needed it in the moment. But it also, I think, might reflect the nature of the reporting about her suicide death. And those are some of the biggest challenges that we have in this field. So again, very complex, many risk and protective factors. There is no one organization, no one person, no one funder who is responsible for addressing all of these. You know, it's not the federal government's responsibility to make all of these risk factors go away. It's not, or to strengthen these protective factors. There has to be coordination and collaboration and cooperation, and you know, we're not seeing that right now, and that's a challenge. I did talk about firearms. I wanted to point out that just over half of all suicide deaths, male and female combined, involved a firearm. And in 2018, more males died by suicide using firearm. But that's, you know, I'll talk about that in a minute, but I think, you know, given the country that we live in, while other countries can ban access to firearms, that's not something that is necessarily a possibility in the United States. And so that's a consideration you have to keep in mind in this field, in this work. So I mentioned suicide is not just a mental health issue. Researchers found that more than half, or just over half, of people who died by suicide did not actually have a mental health diagnosis. That could be because they never saw somebody to get a diagnosis and they actually had one, or they didn't actually have one and they experienced a sudden crisis due to job loss or interpersonal violence, or related to substance use or some other issue, relationship problem. There's so many different, I think, factors that can take place in the weeks and months before somebody actually attempts suicide. So it's not just a mental health problem. And I think any effort in the future to strengthen suicide prevention really needs to take that into account. It's not just the behavioral health field's responsibility to deal with, or healthcare for that matter. So it's really complex, and that's what makes it a public health issue. It affects millions of people, even though, you know, a fraction of that number actually go on to die by suicide. It is a leading cause of death. It affects a majority of age groups, all races and ethnicities. And it doesn't just affect the people who actually go on to die or attempt, it affects their families, their friends, the people in their network, the healthcare system, educational systems, you know, emergency response, people who, you know, the systems, the services that are having to respond in the moment. Many risk and protective factors, no single cause, no single solution. And I think because of all that, you know, suicide rates have risen over the past 20 years. There hasn't been an effort to date that has really, on a wide scale, figured out how to fix this. So that's something that, you know, continues to be a challenge, but there is hope. So before I talk about the hope, I want to talk about some of the challenges a little bit more in detail. So the biggest challenge, or one of the biggest challenges, is just overall lack of funding. Some of these are interrelated. So there's also lack of access to real-time data, which we talked about already. You know, with the COVID-19 pandemic, we had access to real-time data. We have that. We go, there's so many different dashboards out there, and we can see what's happening in our own counties and our own cities. To some extent, with suicide data are 2 years old, and that's the best case scenario. There are other kinds of data out there, like calls to the lifeline, you know, what qualitative data on the texts that are being sent to the National Crisis Text Line. You know, there are other ways to analyze the data to kind of paint a larger picture about what's happening. But as far as mortality data go, and that's a really important benchmark, we don't have what we need, and we don't have the systems in place, and that's largely due to a lack of funding. There's a lack of federal funding, especially compared to other major public health issues where we've actually seen progress. So in 2017, for example, the National Institutes of Health, which houses the National Institute of Mental Health, spent $100 million on suicide-related research, compared to almost $700 million for breast cancer-related research. You know, there's such a disconnect, and I'm not at all saying that research dollars for breast cancer or other issues should decrease, but if we want to see change, we have to see an increase in investments in research, in programs, in services. It's kind of, it's scary, it's sad, it's disappointing, but that's the reality we're facing right now. I think especially related to public health preparedness, crisis services are very poorly funded. The federal government probably pitches in the most, but it's certainly not enough to fully staff crisis centers across the country. Crisis centers sometimes are all volunteer, or communities are incredibly rural or frontier, and they just lack community-based resources to support the infrastructure needed to help people who are in crisis. I was on a call this morning with somebody who leads a crisis system in Maryland, and he had to get very creative about ways to make the most of funding that they had access to. So they combined grants that they received with fee-for-service models, billing Medicaid for what they could, getting licenses that would allow them to bill for services out in the community, and so on, and tapping agencies that are not behavioral health related, but definitely have a tie to behavioral health, like the juvenile justice system, for instance, and child welfare, and other, you know, the education system, and so on. And so again, I think that reinforces one, the lack of funding, but also the importance of a connected, coordinated approach, because it's not just any one organization or agency's responsibility. It's got to take everybody. Again, I work in crisis services now, but I'm so new that I will say a little bit more about this, but in the next slide. But what I do know, and what I can say very, very certainly, is that crisis services are fragmented and not well funded at all. I think another huge challenge, and this is related to lack of funding, is there's just a lack of what we know works. There's a lack of evidence for interventions that work. We just don't know what is going to prevent suicide each and every time. We don't know what's going to help people who are disproportionately affected. Interventions that work for, you know, interventions are really that we know work are really designed by people for a specific population. And so, for instance, those might not necessarily work for Native American populations who have a different cultural perspective and an idea about what healthcare should look like and what healing looks like. We've just done a really poor job as a country, I think, on trying to reach people who really need the most help and who are most affected. And it's not just a problem for suicide prevention. That's, you know, every public health issue you can think of. I think I mentioned the unique considerations about lethal means that are, you know, firearms, access to firearms is very political. In my last job, I worked with a nonpartisan, federally funded public-private partnership. And in that role, we did bring together, you know, agencies like the Department of Health and Human Services and Homeland Security and Veterans Affairs and Department of Defense with representatives from the firearms industry, trade association, suicide prevention groups, data people. We brought them all together on this, you know, at the same table, but there were certain things we just weren't allowed to talk about as a nonpartisan group. And sometimes when you are building partnerships, you have to put personal agendas aside. You have to consider where your funding comes from and what you're allowed to do with that funding and what you're allowed to say because of that funding. And, you know, again, we live in a country where the Second Amendment will, as long as that exists, that we won't, you know, while reducing access to firearms or other means among people who are in crisis, there are rules that allow for that actually taking firearms away is never going to be an option. And that's not something that I am endorsing or recommending. I just wanted to throw that out there. I think, you know, I mentioned this is such a complex issue that you have to have a coordinated, comprehensive approach. And you know, that what's really hard about that is we don't have the evidence. There's no one group that's standing up and saying, we're going to take the lead on this and we want everyone to join us. I think, you know, the group that I worked with before, the partnership, has a lot of promise to do that, but still, you know, our country is very large, and you know, every state in some ways is like another country, and so it's just incredibly challenging to really take what recommendations, take evidence we know works, and you know, make it happen in communities, make it happen on the local level. And then we have the COVID-19 pandemic, which we're all experiencing right now, and you know, presents its own set of challenges. So let me just go. Okay, so I mentioned that we don't know right now that there will be any impact, you know, on suicide rates. There are some data to show that suicidal thoughts have increased during the pandemic, especially among young people, and that mental distress you know, we're seeing increased reports of that. The CDC did just a brief survey among adults only that, you know, that resulted in 40% of adults saying, yes, I'm struggling right now. And so many of us are struggling. So social isolation, grief, job loss, you know, instability, from that job loss and just what's happening in our communities. Fear, anxiety, am I going to get sick? Is my child going to get sick? And, you know, the list goes on and on. Being stuck at home with your kids all day, homeschooling. I mean, there's so many challenges. Losing housing, you know, all of that. I think the pandemic is escalating and elevating a lot of these issues, and a lot of these issues that are risk factors for suicide and certainly for mental distress. We just don't have the data yet to show that there is going to be an increase, and we won't know for some time. So unfortunately, social media, there are no rules. So occasionally you have some really high profile people who mean well, but you know, can do a lot of damage online. So for instance, there was a while ago, there was a you know, a tweet that went around about suicide in the UK increasing. And later on, you know, they studied that and found there was no evidence of that, but a tweet is a tweet and it can go far and wide. And then eventually that evolved and came over to the US, and it evolved into a tweet that the suicide rate in the United States is increasing. And I've actually seen, I had a friend who retweeted that recently, but we just don't know. And 200% is actually quite high. And again, there's no data to prove that. We hope that doesn't happen, of course, but I think what gives me hope is that, you know, while the COVID-19 pandemic has been horrible and just awful and tragic, and, you know, you name it for so many, it's really forcing conversations that wouldn't have happened as quickly. And it's not just the COVID-19 pandemic, it's everything happening in our communities related to racism and inequality. And, you know, the pandemic is really, you know, forcing issues to the surface, or they've been at the surface, they've been above the surface, but now people are being forced to talk about them and address them. So right now we have an opportunity. Conversations are happening. There seems to be more readiness across more sectors and industries to at least address mental health as a really important issue. And hopefully if you address mental health, you can, you know, prevent things like suicide that might happen downstream. There's just more investment, more discussion. And I've seen it from, you know, the entertainment industry and the news media, and even what's happening now with crisis services. There's a lot of hope. There are a lot of things happening, a lot of talk happening. And you know, that's all good. That's all good if it results in actual change. So one thing that you probably saw in the news recently is that the president signed into law 988 as a new 3-digit crisis line that will go, actually, it will be fully implemented in July 2022. So in less than 2 years now. It is actually, T-Mobile the other day just announced that it's made it live on its networks, but it's not actually, you know, it's not the number that we're recommending people call right now. Everything gets routed to the National Suicide Prevention Lifeline number. The challenge is that, you know, a number that is easier to call might result in increased volume to those lifelines, and there isn't increased funding that's going along with this number right now. So I don't know, from an, you know, emergency preparedness or public health preparedness perspective, I think this could be a really interesting issue to investigate. There could be a really fascinating case study that comes out of this. You know, what happens after people call 988? You know, are communities ready for it? Are crisis lines ready for it? Is, you know, if funding and infrastructure isn't in place by July 2022, when this thing fully rolls out, you know, it could be a disaster and that we can prevent with the right conversations. But I don't know, you know, this is the work that I'm going to be doing. I'm going to be helping the Lifeline prepare for the rollout, working with so many other people. But keep an eye on that, because it affects emergency services, it affects communities, it's not just a crisis services or crisis system healthcare related issue. it affects law enforcement and everything. So yeah, I think it's going to be really interesting, and hopefully works out for the best. We are seeing some increases in funding. Federal funding has increased. It didn't increase for such a long time that the increases now that we're seeing are pretty small, but they're still increases. And we're seeing funding from the CDC, and not just the mental health, the Substance Abuse and Mental Health Services Administration. There's funding being routed to Homeland Security. There's funding from the Department of Justice. So we're seeing increase in the sources and the kinds of funding that are out there. Also, for those who are familiar with healthcare or work in healthcare, the Patient-Centered Outcomes Research Institute that looks specifically at healthcare related, what works in healthcare. They just released funds to support suicide related research. So, and their whole mission is to investigate healthcare related services and treatments and effectiveness of those among populations that are disproportionately affected by a particular issue. So I'm really excited about that. There's also increased private sector involvement and investments in suicide prevention. There's increased readiness among the news media. I think there's so many news outlets across the country that it's still going to continue to be a challenge, and it's a challenge, especially now during the pandemic. Best practices for reporting on suicide have been around for a really long time. There are versions in Ireland and the UK and in other places in Europe and around the world. Australia has them, but it's just not uniform at all. But there is increased readiness. There are allies, especially in some national news outlets, so that there is promise. What is the company? A corporation, I can't remember the name, but they just created a tool that news media can use to it kind of works like spell check, but they can add their article to this system, and the article will pick up red flags where the reporters actually went against the national reporting guidelines. So, and might offer a suggestion on how to make it better. So I think that's really neat. That was a really expensive investment they were willing to make because they thought it was important. So we're also seeing increased evidence showing that healthcare interventions work. I think that's where the National Institute of Mental Health has invested most of its work. They've studied other things like news media reporting, entertainment industry, behaviors, but healthcare interventions like following up with people after they have been released for a suicidal related crisis, safety planning, where a provider is sitting down with somebody in crisis and they're talking through, okay, what do you have access to at home? What are your plans? How are you going to stay well? Who are you going to call when you need support? There's increased evidence showing that those things are effective. So some priorities to wrap up. I mean, we need to expand funding sources and amounts. It can't just be the amounts that we've had, if you account for inflation, they're not actually increases at all. It is everybody's role to play, to help prevent suicide. And we need the federal agencies' leadership to kind of come up to step with that. And also see expanded funding from the private sector. I mean, that probably has the most potential. And so that's something that has to be a priority for the future. We need more research on what works to prevent suicide. We don't invest enough in evaluation, and we don't invest enough in research among suicide prevention for populations who are most affected. 988 rollout is going to affect everybody in the country, whether they're involved in suicide prevention or not, or whether they're involved in crisis services or not. So that is a huge priority over the next year and a half, and even afterwards, as we see it being implemented. We need to see more adoption and evaluation of healthcare interventions. There are some health systems that are quite large, that are more regional, and they're actually investing dollars in researching interventions outside of their own health system. So they're investing in pilots of healthcare interventions they've adopted for their own network in systems that they don't own or that they don't run. And so there, I think there's a lot of promise there. And then the plan is to scale those up over time. And then access to real-time data, we have to find a way to, have a system that states that leaders and communities that, funders can have access to, so they can make decisions about how to invest and where to invest, and where public health professionals need to really focus their efforts, so they are making the most of their, the time and effort, and can result in the biggest impact. So I'm going to stop there. Again, broad overview, just skimming the surface. But I'm going to stop talking and give you the chance to ask questions. I'm sorry that we only have 7 minutes left to do that, but yeah, kind of want to open it up now and see what you might be thinking.
Thank you so much, Farah. I really appreciate you talking, and I'm gonna take this opportunity to make another plug. I am gonna put a couple links in the chat. The first one is one that I have shared a couple times, but this is the resources that are available to Penn State World Campus members or World Campus students. If you need them and you don't know where to look for them, please get in touch with us. Any of your faculty members will be able to point you in the right direction. And if there's something that we don't know, we will find the answer for you. There's also I mentioned, you were talking about law enforcement.
Mm-hmm.
We have a webinar on first responder mental health. And that was something that a lot of people overlook. And again, right now with COVID, we've got so many people that are getting burned out. So
yeah,
that is the site where this webinar is going to be posted as well.
Mm-hmm.
So I'll ask the first question, and then if anybody else wants to either put one in the chat or raise your hand, we can go down the list. I was reading an article a couple of days ago. A woman's brother had committed suicide, and she was on and she was saying how, we are trying to make, people who have cancer go to an oncologist. People who have depression or mental health should be able to go to a provider like that without the same stigma. And she had a problem with the expression committing suicide, because you don't commit cancer, you don't commit a heart attack.
Yeah.
And I noticed that when you were speaking, you said deaths by suicide or suicides. You didn't use that term. So was that a deliberate,
yeah,
wording choice?
It's a wording choice. It was deliberate. And that is, it's, probably based on people with lived experience, like the woman in the article, and so many other people who have either attempted suicide and survived, or have lost loved ones to suicide, that there's a lot of stigma for people who survive, because suicide is such a, you don't talk about suicide, and committed suicide has been used for such a long time. It's really entrenched in people's dialogue and language. But the idea is that if you say committed suicide, you're just perpetuating the challenges that people experience, and kind of being open about what's happening. That, yeah, you commit a crime, but you don't commit, you have to talk about suicide like it is a public health issue. And so you die by cancer, you die by, heart disease, you die from other public health issues, you die from suicide. So part of the challenge is it's been relegated to, such a taboo place for just, historically. And so we're still trying to get to a place where people talk about it and treat it like the health issue that it actually is.
Thanks. All right. So I'm going to, does anybody have any other questions? There's one in the chat. How large of a role does accessibility and cultural acceptance of mental health play in suicide?
That's a great question. And I don't know if I have the answer to that. I would say that, cultures and communities and populations view suicide differently. In my last role, I worked with a faith community task force, and our goal was to engage faith leaders as partners in suicide prevention, because they were really important gatekeepers. you have to engage your gatekeepers and get them on board so that they can kind of be your, ambassadors out in communities where suicide prevention actually happens. But there are a lot of faith communities that see suicide as a sin, and so you don't talk about it. And I heard a story today in a conversation where, this leader of a crisis system was saying he would get somebody out of a crisis and then back into the community, and then they'd go back to their, faith community, whatever it was, and then be convinced to go off their medication or off whatever treatment they, were put on to help mitigate the crisis. And so it's not just faith communities. It's different populations, different cultures view suicide differently. And I think the key takeaway here is there's not a one size fits all approach. You have to consider your, the population that you're trying to help. You're not helping them if you're doing it without them. You have to put them front and center, get their input, what's going to work for them, what's not going to work for them, and take all of those considerations into play.
This is from Dr. Langridge. The recent news is that Japan had an epidemic of suicide during October. What is preventing us from having the same data as quickly? It seems that suicide should be a more easily coded death.
Oh, Jean, that is such a great question. I love that question. I don't know the answer, but my guess is it's such a different system there. There's a different kind of health system. There's a different size population. There are different politics. Our method for collecting and reporting data and funding it is so complicated, from the time that it goes from the coroner to the state to a federal system that they just got funding for. There's so many people involved in so many layers, and things are not always coded in the right way. And so I would say it's probably one of those things where it's an apple to orange comparison versus apple to apple. And I know that's probably not a good enough answer, but that's the best I have.
Yeah, okay, thanks. Yeah, it just seems like this, maybe I'm naive, it just seems like suicide should be a more easily coded, recognized death than many other ones, and would have to go through fewer layers. Maybe I don't know, but it just seems like we should be able to have those data more quickly, particularly when I think about public health preparedness, I've always thought about suicide as a problem for the people who do public health preparedness. I never thought about the actual suicide being part of the epidemic that we're now experiencing. So, or potentially part of the epidemic.
Yeah.
I mean, yeah. We need some better surveillance data.
Absolutely. Yeah.
Yep. Here's another one. What's the first best step to talk to someone who's expressed their willingness to commit suicide?
Oh, that's such an important question. I don't have the answer in my head, but I know where to find it. I'd rather send you a link that you can have access to, kind of a script, what to say to somebody who's talking about suicide or considering suicide. It's written by the experts, it's been vetted and everything. And so I promise to get that to Jen to pass it along, because I think everyone should have that as a tool in our lives, at work, personal life, friend, so that we can actually be part of the process to help.
All right, let's see. Are there any more questions? I don't see any hands raised. Any last questions? Okay, it doesn't look like it. So is there any research on this, on the secondary suicide rates when a family member commits suicide?
Yeah, there are data showing that having a family history of suicide is a risk factor for suicide, which means there is research out there. I don't have it at my fingertips, but it's an important risk factor for suicide. So family history, somebody, a parent, a close relation, a friend, you know, who died by suicide, that, you know, they're at higher risk, or there could be a higher likelihood. Doesn't mean it's not causal at all. It doesn't mean it's inevitable. It's just you know, increases the risk.
Yeah, and we have had some, you know, localized clusters of suicide too. Some copycats, so high schools, for example.
Yeah.
So those are outside of the family, but we've seen those sorts of things from the public health data perspective.
Got some good questions over here. Are there any more? All right, it doesn't look like it. Give it like 1 or 2 more seconds just in case. But oh, is there? Oh, thank you. Okay, so thank you so much, Farah. This was a great presentation. It was amazing to see you again, and I really appreciate all the great information that you had, and especially the links and phone numbers at the beginning.
Yeah.
As I said, I'm going to post her whole presentation, but I'm going to pull that slide out and I'm going to post that separately, so that way we've got it all easily accessible, along with again, I'll post the Penn State resources, so that way we all have them. But thank you again. We really appreciate this. And again, we are going to be, our next one is going to be in February, first Wednesday of the month at 8 p.m. So I hope everybody has a very safe and happy holiday season, and best luck with the end of the semester coming up. But thank you so much, Farah.